Okay. I'm not really sure why we're having a hard time like getting everybody together. I was in a meeting with some other people. Doesn't matter. Um, I'm gonna post this. There isn't anything that really that we're gonna go over that you don't see in front of you already. Um, and a couple of you guys have asked me like, do I make this off of the test or do I do it from the text and the PowerPoints? And I do it from the text and the PowerPoints. I don't have access to the test typically. Um, so we'll go through some of this and I'll try and pull up I'll try and fill in some blanks here, but for the most part, like this really is just to guide your um it's just a guide your studying of the material that you've already learned. I do know that she's very PowerPoint heavy. So if that's helpful, you can follow the PowerPoints. Um, Somebody was able to connect. Hi, Kira. I'm not sure what's going on, but I just started the recording and I'm just gonna go through everything until other people can join. I'm not entirely sure what's going on. Um, so you should be able to see my screen with the review up.
Yeah, I can.
Okay. So I mean, you guys really just kind of sit there and listen to me talk anyway, so I'm just gonna send this, I'll record it and send it out and um hopefully it helps. I did say before that I'm pretty sure a couple of you guys have asked me if I do these reviews like to the test itself or to the content and the text and the PowerPoints. I don't have access to the tests. So this is all based on just the same material that you guys have, just from a different lens. Um, and I'd said before also that the professor seems to be very PowerPoint heavy. So while there's gonna like I know she says everything is fair game, the stuff on the PowerPoints is a pretty good guide for what you guys should be looking at. So while I cover the stuff in the um review here, I'm gonna also kind of look at what's in the PowerPoints to kind of gear you guys in the right direction. Um, so chapter 12 was cognitive wellness in older adults. The definition that they use for cognitive wellness is the ability to think, learn, and remember things, solve problems, and make decisions. This can have normal aging effects, but like the ones I'm going to list, but typically a lot of these like cognitive decline issues are not a lot of the ones that are not listed here are not normal, and we've talked about that before, so just keep that in mind as we're going forward. But the what's considered normal cognitive signs of aging are processing speed may be a little bit slower, word finding might take longer, learning new information might require a little bit more repetition. Um, but this should not impair the ability to live independently. Um, If you go into the PowerPoints, she does cover, it looks like there's three or four theories on um, cognitive cognition and aging. Um, the conclusions for theory one say that is there is a great deal of individuality in the variability in cognitive abilities, that multiple interacting factors influence cognitive aging, and each adult may experience a mixture of decline, preservation, and improvement in cognitive abilities. Um, cognition and aging theory number two um, says that there is a decreased cerebral blood flow, cortical volume loss, particularly in the frontal lobes, and that reduced brain weight, enlarged ventricles, wider um, sulci, and loss and shrinkage of neurons can all accumulate into like decreased brain functioning. So if you look at image studies of the brain with aging, it does look like there are physical changes. Um, Theory number three talks about fluid and crystallized intelligence, which we're going to touch on a little bit later. And theory number four talks about memory, that it's conceptualized like a computer like information processing and the primary memory is short duration, small capacity and like a holding tank, whereas secondary memory is a lot longer. It's important for the retrieval of information and it's used for storage. There are a couple of related theories to memory, but what she doesn't have those up, so I wouldn't go too crazy with those. Um, let's see. Abnormal cognitive changes, if we're going back to the review sheet here, abnormal cognitive changes that are not normal, rapid memory loss. So somebody should not be like having incredible difficulty with short-term or long-term memory, being disoriented to person, place, or time, difficulty performing activities of daily living, and personality or behavioral changes. Those are all red flags that you want to look out for. That if someone were to come into your practice and say their mom is experiencing these issues, these are abnormal and should prompt further assessment. Um, Memory systems that also that are affected by aging. There is working memory may need more time, like we mentioned before. Um, it was explained to me when I was in school, like the fact that by the time you're in your older adulthood, you have so much information in your brain that it takes a while to go through it all to pull out what memories and information that are relevant to what we're talking about. Um, and that because of the decreases in the physical brain itself, that everything kind of moves a little bit slower. Um, Long-term memory, though, is typically preserved. Although human memory is fallible in and of itself, long-term memory about, things that have happened to them throughout their life should remain intact. Remote memories remain strong, especially personal events. So here's the crystallized and fluid intelligence. Fluid intelligence is the ability to solve problems, process information quickly, and this usually decreases with age. Crystallized intelligence is knowledge, vocabulary, and wisdom gained through life. This remains stable and increases with age. Um, so fluid intelligence is kind of like the ability to learn, whereas crystallized intelligence is kind of what you've already learned. Your cognitive reserve is the brain's resilience against age-related decline. So this part of your cognitive reserve is going to be part of that crystallized memory. Um, and this is strengthened by like active engagement, with learning and activities and like physical movement and things like that. I know we covered that, I think in on the last test or maybe the test before, where um like the use it or lose it kind of concept, that if you stay engaged and you stay learning, then that kind of stuff, those muscles, so to speak, will remain strong. Neuroplasticity, the brain can form new connections when stimulated. This is a newer concept that we're starting to see a lot more of. The concept of neuroplasticity is that it is pretty constant throughout life, although it does taper off in older adulthood. This is the ability to kind of rewire your own brain. We talk about this a lot in like psych when we're talking about like cognitive behavioral therapy and things like that. It's just the ability to um, rewire or form new connections when you're stimulating your brain in a different way. And that really boils down to like mostly your like thought processes and like the thought patterns, their neural pathways are absolutely malleable. Factors that can support cognitive wellness. This is all very basic, common stuff that you guys already know. Social interaction, physical activity, mentally stimulating activities. Um, Managing your hearing and vision loss, which is a big one. A lot of people, there's actually studies that show that hearing and vision loss can potentiate early onset dementia and effective management of chronic illnesses. Obviously, the sicker you are, the harder it is for you to maintain yourself. um, mentally sharp. Factors that impair cognitive wellness would be isolation, depression, chronic stress, misuse, and medications with the anticholinergic effects, which you guys should know from last test that elder adults should not be taking anticholinergic medications at all. Mild cognitive impairment, this is like a term that you'll use for that abnormal cognitive decline. Um, and it's when the cognitive decline is greater than expected, but it still doesn't really interfere with daily function. The you might remain the older adult might remain stable or improve, but it also could progress to dementia. These are the people that if this is on their different or if this is on their diagnosis list, that they're kind of in that limbo. They have the opportunity if they can to kind of come back from it, but um if they were to fall into any of these things up here, these cognitive impairment factors, that we might lose them kind of to like a more progressive thing like dementia. Things that nurses can do, these are always important to pay really close attention to for the test because the test is teaching you how to be a nurse. So pay really close attention to anything that says like the nurse should do this or how can the nurse help this. Nursing actions that promote cognitive wellness would be to encourage participation in social and mentally engaging activities, promote consistent sleep routines and a healthy diet, encourage safe physical activity when appropriate, and use calendars, labels, lists, and medication organizers. That's falling back into like making sure that they're staying sharp with reading and memory, and use hearing aids and glasses when they're prescribed. Providing reassurance and reducing stigma around age-related changes is also very important, and to keep an eye out for those red flag signs that something might not be this normal signs of aging. Um, it looks like she covers a lot of different stuff in the PowerPoints. I didn't include a lot of it because it would just be me rehashing everything that's already in here. Let me see if I could just switch over to um, a different app. Okay. So we kind of went through these like top four aging theories and the memory stuff here, lifespan theories. I don't, it really depends on how much she like kind of weighed in on this like while you guys were in class, but um the achieving stage is within early adulthood. Adults apply acquired knowledge and demands and commitments such as career and family. They use their intellectual abilities to establish their independence. Responsible stage is these late 30s to 60s. They integrate long range goals and attend the needs of their family and society. This is a lot, they like to call this the sandwich generation a lot because they're taking care of their children and likely their older parents. Um, Executive stage, it applies to people with high levels of social responsibility. Reintegration stages, older adults apply acquired knowledge to. Um, their current interests and values. So this might be pulling away from their adult children and putting more of their time and effort into the hobbies that they really like, or focusing on their retirement goals financially. And then the legacy creating stage is where, grandma and grandpa tell you a lot of stories about um, their own life. They also tend to focus a lot on their will and testament at this point in life as well, as they kind of near maybe the end of their life. This empowerment theory focuses on self-determination, choice, and control. This theory itself, like, is while it's very important for older people, it's important for everybody. Empowerment is a process of moving from a state of powerlessness to and passivity to one of control. Um, this is going to be a big part of your like nursing interventions, like kind of throughout school and your practice is handing back the power to the patient so that they can kind of make their own choices, um, which helps them. in general, just thrive. Neuroplasticity we covered, and cognitive reserve we covered. Um, Factors that affect wellness, we also kind of covered this in the review. Aspects of brain health, cognitive health, ability to think, learn, and remember, motor function, and the ability to make and control movements, emotional function, ability to interpret and respond to pleasant and unpleasant emotions, and tactile function is the ability to feel and respond to sensations of touch, including pressure, pain, and temperature. Um, these these should all stay relatively intact with only slight declines. Like we said, anything significant we want to be assessing a lot further. We talked a lot about this. The medications, like we said, there's sleep medications, there's the anticholinergic medications, certain blood pressure medications, antidepressant medications. These can all have kind of almost slowing or depressing effects that might impair someone's cognition. So let's keep a close eye on those medications to see if that might be what is throwing up red flags as far as cognition and an assessment in an older adult. Delirium is different from dementia in that delirium is an acute fluctuation. Um, it's a disturbance in attention and cognition. It usually is pretty rapid and it's often reversible. Delirium is what you'll see in things like UTIs, um, older adults who are admitted to the hospital for a longer amount of time. You'll see this in psychiatric emergencies. This is, like we said, an acute kind of thing, and it is often reversible. Like I said, it's common in hospitalized older adults because you're pulling them out of their normal environment and now they're sick as it is, and now this is everything is just compounding into um a delirium episode for them. It is often underdiagnosed or mistaken for dementia. As you go through your practice, you'll be able to kind of pick out the difference between the two, but this is a newer conversation that we're having um, in the inpatient setting as far as nursing goes, to be able to delineate between the two and intervene accordingly. The couple types are here. I would pay keep an eye on that and pay close attention. There's the hyperactive versus hypoactive, and then there's mixed. That's pretty self-explanatory. We talked about some of this stuff. The predisposing factors are pretty clear. All it has everything to do with what we said was the factors for cognitive decline on its own. And then the precipitating factors, like I said, are infection. This would also be electrolyte imbalance, hypoxia. I've seen even young people come in with hypoxic delirium. It's pretty wild. Medications, withdrawal, environmental changes, surgery, pain. Um, there's a mnemonic for you. I would think that that is a sign that this is an important thing to know. Um, the assessment tools, the management here, I would pay attention to this as well. It seems organized in a weird way, but I think paying attention to like these top ones here are important, assessment tools, this CAM. She loves the CAM thing. She constantly refers to the CAM. Um, the management, we're going to identify the cause, reorient, avoid the restraints. That's also important. And then involve the family members, prevention strategies, avoid the medications, keep them oriented with different tools like clocks and calendars and keep them moving. We talked about that stuff. Mild cognitive decline we talked about, and then nursing assessment, um, neurophysiological testing, psychosocial testing, and then formal assessment of the intellectual performance. And those are a little bit more in depth with the nursing assessment, you're going to just really keep a close eye on like their mobility status, their whether they're alert and oriented or not, and kind of where they fall in like with their temperament. Are they incredibly agitated? Are they hypoactive? Do they seem depressed? Um, and that, we'll leave it kind of at that. These nursing interventions, I did mention here, refer to if there's a box to refer to, I would refer to that. I would go in and find that box. I might have it up here. Let's see. What did she say it was? 12.2. Yeah, these are the 12.3. 12.2 is a pretty good box. This is pretty good too. So I would keep an eye on that. Look at that one. That kind of is what we just talked about on how to kind of delineate between the different stuff. And then these seem important too. This 12.3, I would keep an eye on that. We kind of went over the general concept of that, but this is like more specific things that you can do and educate your patient on. Um, Mentally stimulating activities we talked about. Effectiveness of the interventions we're going to measure their satisfaction with their own cognitive abilities, and we're going to measure their ability to use cognitive skills in their daily activities. Outcomes addressing the risk factors. We want to improve their sensory function, control cardiovascular disease, smoking cessation, healthy lifestyle practices, etc. These are some questions that I'm sure might, a lot of the times they'll use like a kind of a general concept of what the question was about. And like, see this one, I said, it seems like this might be important to know the differentiation between dementia, depression, delirium, and a mild cognitive impairment. I would grab the general concept of these checkpoint questions and, go back to where that information is in your material. To kind of prep yourself for what might be on the test in regards to this particular PowerPoint. All right, we're going to move on to chapter 13. So this is the psychosocial wellness in older adults. Psychosocial wellness includes mental health, identity, coping ability, relationships, purpose, and life satisfaction. This is influenced by physical health, social supports, past coping patterns, and life events. Um, let's go into the PowerPoint here. These are the challenges. This is just like what I just said. This is the opposite of things that could go wrong with the list of things that I just listed. Certain life events. So we talk about the major life transitions that come along with an older adulthood and what might affect their psychosocial wellness. This is retirement. This might be positive, but it might also be very distressing if they don't really have an identity outside of work. Relocation or changing in living situation. A lot of older adults have to go live instead of living by themselves anymore. They might move in with their child, or they might go into assisted living, and then loss of a spouse, loved ones, or friends. It's just a natural part of life that as you age, your peers age, and losing a handful of your peers and especially your loved one might have a very strong effect on your psychosocial wellness. Ageism, those stereotypes and negative assumptions based solely on age, can absolutely reduce self-esteem and discourage independence. This is where nurses come in the hospital and kind of combat that. And it's important to communicate respectively, support their autonomy, and meet them where they are cognitively, not where you think, someone in their 80s or 90s might be. Loneliness and social isolation is something that obviously we've talked about can affect everything. Loneliness is the emotional state of lacking meaningful connections, and social isolation is the lack of social contact. Um, Both of these can increase the risk of depression and cognitive decline and potentiate physical illness. Um, Going into these, let's see, chronic illness. One thing that's not listed up here is that major life transition is the impact that chronic illness and functional impairments can have on older adults. It sometimes can be inevitable that older adults will have chronic illness and decrease in function. This can lead to loss in independence, like and adjustments in daily living. For instance, people who are on dialysis face this issue a lot, that they have to be at dialysis at like 5 in the morning, sometimes 3 days a week, and they're unable to drive themselves to that because it's basically the middle of the night, it's dark, and um end-stage renal disease is very compromising in and of itself. So things like that can lead to a total different view of the world if like we're going to talk about here, unable to drive. I think this is like a hot topic. This is this can lead to, while if they continue to drive, it's dangerous, but if they lose the ability to drive, they've also lost their autonomy and their independence. They're unable to live their life kind of independently. Um, Now they have to rely on other people for rides, and it's difficult to get from point A to point B, especially if they have multiple chronic illnesses and need to get to 3 doctor's appointments in 1 week. This can be a very big life event that will absolutely affect their psychosocial function. Um, so here's those checkpoints again. This one has to do with the decision to give up or significantly curtail the driving is considered a major life event. It absolutely is. I would delve a little bit deeper into this if there's stuff in the book about it or whatever she said at the during the lecture. Um, let's see. Widowhood, we kind of covered the loss of um, your spouse. Women become widowed much more often than men. They should follow this like particular trajectory, and that you lose the spouse, eventually you'll rebound or recover, and then hopefully you'll not get over it, but get past it, be able to live your life, or you'll live in this kind of like enduring grief, which is a whole nother concept of like complicated grief. Um, the loss of, friends and family. We also kind of talked about another checkpoint. This one talks about ageism. I'm sure this is going to talk about, yeah, I'm sure this is something will be tied into this about nursing interventions and ageism. Um, Theories about stress and coping. I think this is kind of where we left off over here. Um, Stress is defined as the sum effects of all the factors that act on the body. Normal stressors could be normal activities, disease states, both pleasant and unpleasant. Um, she references the social adjustment rating scale. Not that you have to mention the whole entire thing, but just know kind of what it does. Oh, I guess, well, she does like the whole. mm. If she were to, if anyone was ever to put this on a test, they would provide you with this actual thing where you just have to like kind of pull the numbers and add it up. That seems excessive. Um, Theories about stress and coping in older adults, seeking information, these are coping mechanisms that you guys that should be used, reframing the situation, maintaining hopeful outlook, using stress reduction techniques, channeling energy um into physical activity, creating fantasy, finding reassurance, getting involved in activities. that involve the arts, coping styles categorized as or problem focused or emotionally focused. Why this is relevant for nurses seems important. Identify interventions that optimize functioning and quality of life, psychosocial intervention, deal with chronic conditions to remain at home safely. Religion and spirituality can pull heavily into someone's psychosocial functioning, finding somewhere where they can finding one of these religions or spirituality theories could really help someone, find meaning in what's going on in their lives. And knowing where someone, identifies in this realm could also help kind of um, pull some motivation out of a patient. This may provide comfort, guidance, and purpose. It does not require a religious practice, and nurses support the personal beliefs and access to spiritual resources when desired. Um, and then influence psychosocial, let's see, this is generativity, um, which is the integral component of spirituality. If this it's really just a general like doing good for others, so that you are providing, something meaningful in the world. Um, it kind of can provide like a greater self-perception, when you use it properly. Cultural considerations, the cultural influences it's just the way that people kind of perceive everything. Cultural bound syndromes, specific manifestations, and then folk or indigenous healing systems. That's an example of like how some people might deal with aging in a like a cultural sense. We talked about risk factors here: poor physical health, impaired functional abilities, weak social supports, an occurrence of unanticipated events, occurrence of several daily hassles at the same time, and then several major life events over a short time. Looks like there's a box reference here. Um, like I said, look those over. In my experience, I see a lot of here we go. Oh, this one's all on alcohol abuse. I've seen professors pull like the most obscure details from like the most random box in the textbook. So if they provide you with a box number, I would reference it. Um, Loneliness and social isolation, we kind of covered. Resilience. Resilience is the ability to adapt to adversity while maintaining social emotional equilibrium. It's not being thrown by like kind of what we said before, like that over occurrence of stressors. And this is strengthened by healthy coping mechanisms, social support, spirituality, humor, and life experience. This is also referenced here as the idea of growing old, not just getting old. And it's like we said, linked with these um healthy coping mechanisms. She once again refers to that box through 13-1. Seems important. I'm not going to go too deep into this, but there is alcohol abuse is the most misused. Alcohol is the most misused substance in older adults. They might begin drinking to a psychosocial stressors, and then it becomes like part of their everyday. Alcohol misuse needs to be addressed through interprofessional collaboration, with nurses having an essential role in identifying at-risk older adults and facilitating referrals or multidisciplinary approaches. Um, as is the answer for everything. So she does reference this box a couple times. I would definitely take a look at it. Um, Nursing assessment, we're gonna assess the whole thing from, from the top down, from broad to specific. The range of social and cognitive and emotional aspects of functioning, planning for wellness outcomes. The nursing outcome classifications is a psychosocial adjustment to life change, self-esteem, adaptation to physical disability, body image, and grief resolution. The interventions that help me promote healthy psychosocial functioning is incorporate communication techniques, promote a sense of control, um, address spiritual needs, make sure you were reviewing their life and reminiscence. They just love to talk about things that they've been through and what advice they can pass on to the next generation, healthy aging classes, and improved functional abilities. There's another box um, to reference. This is 13.2 is those intervention to promote self-esteem. She mentions here that good self-esteem is the emotional component of self-concept base. It's just how you view yourself. Good self-esteem leads to happier, healthier individuals. They're less anxious, they're more independent, they're more confident. Identifies the factors that promote that and minimize the threats to it. We see this a lot, this like treating elder adults like, infants. I don't think that I would assume is a no-no. I don't, but sometimes these books like do weird stuff. Yeah, avoid the infantilization of the older adults and elder speak and baby talk. You just talk to them like they're adults, not like they're babies. And avoid giving them pet names like honey or sweetie. Um, promote a sense of control. This is like that it goes back to that empowerment that we talked about in the last slide. And here's another checkpoint. Um, a modified form of speech directed toward older adults resembling baby talk. This you'll have to kind of like go through what she said in class because like I don't really know what she means by that. But if it's in here as a checkpoint, whatever she said, I would reference it. Um, because what I have here, this is avoid elder speak. So, for example, yeah, this is absolutely something to avoid. Um, if we go back into my review, um, we talked about like that life review and reminiscence. This supports Erikson's stage of integrity versus despair. Here we're talking about um like the legacy that they'll leave versus not feeling like they completed enough in their life. Um, communication strategies we just covered and nursing interventions we covered as well. All right, we're gonna move on to chapter 16. Okay. Depression and suicide in older adults. Depression is a common mental health condition that is frequently unrecognized and undertreated. Depression is not a normal sign of aging, and it can negatively affect all parts of life. An overview of late life depression is that it is common, but like I said, often undetected and undertreated. It may develop gradually or follow a major life event, like we talked about in the last um, slide. This is that like unexpected loss, retirement, moving into a new place, losing a spouse, losing friends, illness or medication change or loss. Chronic illnesses can also lead to like falling into a depression. Symptoms can be subtle and can be attributed to aging, which is why there's a delay in the diagnosis. Um, older adults often report it as physical symptoms rather than emotional symptoms. So they're going to talk about fatigue, pain, or sleep changes. Um, and the reason it's so important to recognize is because it does absolutely heighten your risk for physical decline, hospitalization, and suicide. There are two types of depression. Um, oops. The first is major depressive disorder. This is persistent, sad, or empty mood, loss of interest, appetite, weight changes, difficulty concentrating. These symptoms last at least 2 weeks and interfere with daily living. Sorry, I'm just referencing what she has here. And then minor sub-threshold depression has fewer and less severe symptoms. It still impacts your quality of life, but it does like it's before it really affects like your entire life. Like it really hinders a lot of your functioning. There's no single theory, I guess, about theories related, but there are two that we kind of touch on here. There's this learned helplessness that, as people, this ageism has potentiated this older adults to believe that as aging happens, we lose control over things. There's no point in trying. The learned helplessness leads to this like what's the point kind of thing. And then there's the cognitive triad, which is a negative view of self, environment, and future that contribute to and reinforce depression. The links between depression and physiological changes, there are pathways that link depression and medical conditions. Post-stroke depression is um, very common. You'll see that a lot with because it is essentially like a rewiring of the brain, and vascular depression is going to do the same thing. The vascularization and then the neural pathways are all kind of intertwined. When one gets disrupted, you're going to see a disruption in the other, and it could lead to depression. Um, Here's a checkpoint that says that we're talking about psychosocial theories. Um, And the answer that she chose was that the impact of loss, buffering, effective social supports, and social network. This is the cognitive triad theory, refers to the realms of self-image, environment, and experiences. Biological theories investigate the relationship between the changes in the brain, and then Beck's theory focuses on the components of personalization, minimalization, and overgeneralization. Our risk factors are here: social isolation, loneliness, lack of emotional support, just like the same as everything else. This is going to be the same thing here that we just talked about in psychosocial: chronic illness, pain, sensory impairment, recent loss, medication effects, alcohol misuse. Looks like there's boxes here as well. Let's make sure we reference the boxes, read them over. I don't think you necessarily need to memorize everything in all the boxes, but to know the general concept of them is important. This is 16.1, and I think she said something about 16.2. These are the medications that can potentiate depression, and then the chronic illnesses that potentiate depression. Um, Functional consequences of depression is that it makes doing everything a little bit more difficult because you lack the motivation to do it, and because you're withdrawn socially, there's no one holding you accountable for doing it. So performance of daily activities really seems to slide. Decreased appetite, weight changes, and sleep disturbances. Um, it's also hygiene. There should also be hygiene on here. A lot of one of the bigger signs of depression that you'll see that is a little bit more subtle, but definitely there is a lack of personal hygiene. You'll also see an increased risk of falls and impaired physical healing because at a certain point, the allostatic load that comes along with depression and stress will affect you physically. Um, there is a let's see, the assessments here. There is a screening tool. Looks like it's a 15 question screening tool. Doubt you'll need to know the entire thing, but definitely know the name of it and what it does. It looks like it does, the geriatric depression scale is just this short form, and this can rate the severity of a patient's depression. It's also important to differentiate depression from dementia. Depression is typically faster onset, and the patient is aware of the symptoms. Nursing interventions, again, very important. Encourage involvement. This is all kind of very similar to what we talked about in the last place. Adequate sleep, nutrition, manage the chronic illnesses, provide education, and reduce the stigma is important. Because sometimes when you're sliding into a depression, you don't know what's going on because it is a little bit of a kind of gradual slide rather than like one day waking up and feeling that way. Make sure you're referring where important and referring to counseling when appropriate. And then SSRIs are typically the first line. Teach that these medications typically take several weeks to work and can also initially increase the risk of suicide. Suicide occurs at a higher rate in older adults than younger adults, and attempts are more likely to be lethal. They do have a lot more risk factors or heavier risk factors like severe pain, terminal illness, isolation, and access to lethal means than younger adults. And the that learned hopelessness is a little bit more common. The nurse must assess the suicidal thoughts directly and intervene immediately. Um, Nursing interventions, we talked about this, really alleviating the risk factors. There's more boxes talking about non-pharmacological therapies and then the antidepressant medications. I don't think she typically, let's see, um, relies very heavily on like names of medications, but to know the where's 16.4? Just to know the general idea of it would be important. Like the SSRIs, it's mentioned here that it's, that they take some weeks, things like that. You'll have to know, like things that um you're observing for side effects. It's an ongoing evaluation and for the depression, and it can take some times for those to kick in. Um, Health promotion interventions can act to improve psychosocial health. What is the intervention that's most useful? Um, Self-efficiently, efficiency. We always want to go back to empowering the patient. Um, I would definitely keep a close eye on those questions and the material that's being pulled in from those. Comparable. Let's see what's. It does look like she talks a lot more about the medications down here. Antidepressant choice, maximize efficiency. SSRIs are the most important ones. I would keep an eye on what the names are for these, since those are favored. You know, paying it to whatever's on. I wouldn't go too crazy learning what's in the book based on those. Maybe glance at those boxes, but if they're on these slides, I would know it. TCAs, these are those same ones that we talked about before. Commonly recommended in geriatrics. So at least 3 times she talks about using SSRIs, and these two are SSRIs. So I would know that. Um, Monitor for hyponatremia, a bleeding risk, QT prolongation, um, and overalls are the best. The SSRIs are the best balance for efficacy, safety, and tolerability. Let's see. We talked about that. And these are the differences that we have between the three. Remember, I did mention in the last slide that the last chapter that knowing the difference between dementia and delirium is important, but pulling into depression is important too, because as shown here, they do have a lot of commonalities, but dementia is a slow decline, delirium is a acute change, and depression has um, more effect on a specific effect on the mood rather than mental status changes. All right, moving on to chapter 19. There was how it happened, to be completely honest, I'm not sure. But initially this had come through in your slides, I mean, in your review from me as sleep. Couldn't tell you how it happened, honestly. There must have been a mix up in like what I have saved in my folders. Um, but chapter 9 is most definitely on digestion and nutrition. So let's pull up those slides. Okay. Age-related changes affecting digestion and eating patterns. They do, older adults do suffer from hyposmnesia and I'm not even gonna try. A decreased sense of taste and a decreased sense of smell. They do decline with age and can reduce appetite and enjoyment of food. The loss of taste and smell may be an early sign of neurological conditions of like Alzheimer's or Parkinson's, but in mild forms can be considered normal. Um, Smoking, poor oral hygiene, odontal disease, viral infections, and certain medications can also impair those senses of taste and smell. Um, these altered taste and smell may lead to increased use of salt or sugar, which obviously can lead to complications in chronic diseases. Oral cavity and swallowing, tooth enamel becomes harder and more brittle, which increases the risks of fractures and losing teeth. The gums recede and bones supporting the teeth decrease in density, which can lead to losing teeth. Oral mucosa becomes thinner and more fragile, increasing susceptibility to ulceration and infection. Things like dry mouth, are common and can lead to difficulty chewing and swallowing, decreased sensation, cracked lips, and increase for dental caries and gum disease. And they also might these things might be a result of medical conditions or medications. So, um, keeping an eye on those side effects is important. The esophagus and the stomach, the esophageal peristalsis slows, so the esophageal sphincter may not function as efficiently. Gastric production is reduced, which can lead to impaired digestion and absorption of nutrients such as iron, calcium, and vitamin B. Gastric emptying also slows, which can contribute to early satiety and reduced calorie intake. Um, the loss of the esophageal sphincter without the decrease in the gastric acid can lead to worsening GERD, um, which can be very uncomfortable and often feel like a heart attack for some people. Um, but once they hit that point of gastric acid production reduction, then that becomes less of an issue. The intestinal tract, the small intestine absorption remains mostly intact. But like we said in this other list, the absorption of folate, calcium, vitamin D, and vitamin B12 might decline. So you'll see those supplemented a lot. Changes in the large intestine include reduced mucosa secretion and decreased elasticity of the rectal wall. These changes predispose older adults to constipation, especially in combination with reduced fluid intake and low dietary fiber. The pancreas, liver, and gallbladder, the liver size and blood flow may decrease, but that shouldn't significantly impair a whole ton because it does compensate. Pancreatic cancer may changes may decrease enzyme production and continue to impair glucose metabolization, which that can increase the risk for type 2 diabetes. Changes in the bile composition in the biliary tract increase risk for gallstones. Um, just touching on these slides. I think we covered all of this. Um, she uses a specific word for slowed swallowing. And this is, I think, just like a cover, like an overview of like what those things do. That mine is a little bit more um in depth on, like, I pulled a lot of that from the book. But if she mentions it here, I would know it. Um, Nutrition requirements and dietary patterns. Older adults require fewer calories but need higher nutrient density. Um, so instead of eating like three big meals a day, they revert kind of like to a toddler diet where they're having like smaller meals throughout the day, and those meals should be pretty nutrient dense. Think like um, fruits and nuts. Things like protein shakes and smoothies, and then also in general nutrient dense foods like whole grains and higher fiber um, snacks like for instance nuts. Fiber intake is important for the gastrointestinal intestinal function and preventing chronic disease. Vitamin D, calcium, magnesium, potassium, and zinc is often insufficient. And sodium and saturated fat is often excessive, contributing to hypertension and CVD. The Mediterranean and DASH diets support healthy aging, cardiovascular protection, and cognitive um, function. Um, she does mention nutrition related changes, like the lean body mass decreases, metabolic rate decreases, bone mineral density decreases, um, early satiety increases, like we said before, cholecystokinin, which is that enzyme that like tells your body that you're full. All of that increases, so the intake of food decreases, salvia production decreases, thirst perception decreases, taste and smell, and gastric acid and fluids decrease. I feel like it would be not unreasonable for her to ask a question about one of those. Um, make sure you're taking a look at these checkpoint questions. We did talk about these dietary requirements. Conditions related to oral care, the lack of teeth may, like we said, gradually increase. We talked about reasons why that is. And then there's a couple boxes here where she talks about dysphagia, box 19-2, and medication effects are also in 19-2. Um, so we're talking about, I think this is going into like those risk factors. Functional limitations such as mobility, vision, and the ability to prepare food, limited access to nutritious meals, cognitive impairments such as dementia interfere with remembering to eat, safe meal preparation and swallowing safety, depression and isolation, decrease appetite and food enjoyment, and food insecurity may um, affect many older adults and contributes to low quality diets and malnutrition. Dysphagia, there's this box 19.19-2 that talks about dysphagia, which is a big issue because it leads to a risk of aspiration. This is the difficulty swallowing and may result from neurological disorders, frailty, or medication effects. We'll see this a lot in like, stroke patients. We're always screening for dysphagia, dementia patient, end-stage dementia, Alzheimer's, and Parkinson's patients as well. Dysphagia increase the risk for aspiration, dehydration, and malnutrition. The nursing assessment includes screening for coughing during meals, gurgling voice, or the sensation of food sticking. Management includes referrals to speech therapy. And then eating properly, like sitting upright, slow eating, small bites, alternating fluids and liquids. Liquids and solids, and good oral hygiene. Um, Constipation is a big issue that you're going to see in the elder adult population. It's common. It's usually related to lower fiber intake, low fluid intake, inactivity, medications, and fear of incontinence. Um, Age-related gastrointestinal transit can contribute to this, but it's not the primary cause. Education focuses on increasing fiber fluids activity, avoiding unnecessary laxatives, and responding to the urge to defecate. Um, let's see. Malnutrition and dehydration. Malnutrition can result from decreased intake, increased needs, or impaired absorption. Consequences include the memory loss, frailty, impaired immunity, increased fall risk, delayed healing, and um, increased mortality. Dehydration occurs due to diminished thirst. The diminished thirst, like receptors and functional barriers to fluid access, and also the use of diuretics. These are the signs and symptoms you're going to look at. The first ones you're going to notice, honestly, might be the lab work, but looking at the dry mucosa, the orthostatic hypotension, the confusion, and dark urine. Mini nutritional assessment looks like there's um, an assessment tool here. Um, that we're going to be able to use to widely screen for nutritional risks. Underweight is loss greater than 5% in 1 month or 10% in 6 months, which is that those are red flags and considered clinically significant. And we did talk about the assessment of those issues, those risk factors we mentioned before: oral cavity, swallowing, weight history, hydration, bowel patterns, cultural influences, psychosocial issues. Um, Nursing interventions, we talked about nutrient dense foods, adequate hydration, fiber intake, the appropriate use of nutritional supplements, promote enjoyable mealtime, ensure oral hygiene, teach constipation prevention, refer to dietitians and speech language therapists. Um, we talked about this stuff and wellness outcomes evaluate by determining the daily nutritional intake that responds to metabolic needs. We're achieving maintaining body weight of at within 110% of ideal body weight for the individual and achieving and maintaining regular bowel elimination. All right, we're gonna move on to chapter 23, safe mobility in older adults. Um, Mobility is essential for maintaining independence, physical health, emotional well-being. Aging affects bones, muscles, joints, and the nervous system. Nurses must understand the age-related changes, risk factors, and interventions in order to promote functional ability and prevent falls. Age-related changes in the bones, bone remodeling becomes imbalanced with age, decreased bone reabsorption and reduced bone formation. Calcium absorption decreases and parathyroid hormone levels rise. Um, the bone formation and that whole cycle is a feedback loop. When one thing decreases, it all decreases. So once the bones start like breaking down, the rest of the feedback loop reduces osteoblast activity, and that can in general leads to osteoporosis and like weaker bones. These changes have a risk of osteopenia and osteoporosis. It's usually silent until fracture occurs, osteoporosis. Age-related changes in muscles, the muscle fibers decrease, motor neurons decline, um, protein synthesis and muscle cell membrane integrity diminish. Um, and then sarcopenia refers to the age-related loss of muscle mass, strength, and endurance, which affects all activities of daily living. While this is an expected change, um, it shouldn't impair at all activities of daily living. This is something that can be um, prevented or like moderated um, for most of a person's life. Joint changes in connective tissue. Joints show progressive wear and tear due to lifelong use. Synovial fluids become less viscous. Connective tissue elasticity declines. Degeneration of cartilage and formation of scar tissue result in stiffness and decreased range of motion. Changes in the nervous system related to mobility. Balance may decline due to diminished proprioception, decreased reaction time, diminished vibrosenses in the lower extremities, visual changes and slower neurological reflexes contribute to altered gait and increased body sway. All of these increase the risk of falling. Risk factors affecting mobility, low calcium and vitamin D, lack of weight-bearing exercise, hormonal changes, smoking, alcohol use, and certain medications can all potentiate those risk factors. Falls are typically multifactorial and often include intrinsic, meaning health and functional, and extrinsic, meaning environmental risk factors. The risk of falling increases with the number of risk factors present. Functional consequences of mobility decline, the loss of strength, decreased endurance, gait instability, increased fall risk. The increased fear of falling may lead to activity avoidance, which, like a feedback loop, will further worsen weakness and instability. I think we covered all of this stuff. Looks like the checkpoint question is about exercise programs to increase strength may help delay the onset of age-related functional consequences. The answer to that is yes. Osteoporosis can cause serious negative functional consequences, even in the absence of additional risk factors. We covered a lot of this stuff. Looked like there's a box that's mentioned, box 23.1, which talks about the risk factors for osteoporosis and for fragility fractures. A big one is going to be like that inadequate vitamin D and calcium intake, but hormonal changes in women just in general with regard to estrogen is a big one. And we talk about intrinsic factors, which is a history of falls, walking aids, pathological conditions, and then extrinsic, meaning environmental factors like physical restraints, um, lighting, flooring, rugs, footwear, shower, toilet bars, exit alarms. These are all things that are considered extrinsic factors. Which statements related to falls are true? The risk of falling increases in proportion to the number of risk factors. Let's see. Common functional consequences. Oh, we talked about that. Common mobility related conditions. Osteoarthritis is that degradation of joint cartilage and surrounding structures. Hip fractures are common and potentiate functional decline and loss of independence um, if they don't heal properly, if they happen very late in life, and they compound on top of other comorbidities. Looks like there's a couple of screening tools here that you'll want to know for the nursing assessment. And as a nurse, you're going to be taking a look at their gait, their balance, their strength, posture, activity tolerance, fall history, medications, home environment, and the use of assistance devices. Things that you can do to promote mobility and safety. Encourage weight-bearing exercises, balance training, and strengthening programs to slow that muscle loss. Address modifiable risk factors such as poor footwear, clutter, inadequate lighting. Those environmental risk factors. Teach safe use of assistive devices and promote caregiver support and education where needed. Um, I am going to speed through a lot of this stuff because we're coming up on an hour and a half. Um, We did cover a lot of this stuff. Looks like she referenced another box here, um, addressing the intrinsic and extrinsic risk factors. This is like the cascade of hip fractures. The goal is to joint replacement surgery, which is important to know. Okay, I do have to step. You're gonna hear my child in a minute as well. Um, best practices for fall prevention are something that she references here, so let's keep an eye on that. Hi, baby. Hi, me. I'll finish up out here. Come on, cutie. Um, the use of technology is referenced here. Prevention and detection is one of the most, so this is those fall alarms, bed alarms, and the buttons that they wear. Come here, Petunia. She did ask one time a question on a case study that you guys covered in class, so I would pay close attention to this case study. And kind of the answers that she went along with these questions. And I think that's going to be it for chapter 23. We're going to get into our last chapter here. Um, I'm trying to get her to wait. I'm sorry. Okay, sorry guys. So chapter 24 is skin wellness in the integumentary health in older adults. Um, the skin is a protective barrier that regulates temperatures, supports the sensory perception and contributes to body image. Aging affects all the layers of the skin and increases the vulnerability to dryness, infection, injury, impaired healing, and malignancy. Um, Nurses play a key role in that assessment, prevention, and nursing um, skincare interventions. My goodness. Second. Age-related changes in the skin there, the epidermis becomes thinner. The dermis generally loses collagen and elastin, decreasing the elasticity and tensile strength. So you'll see the changes you'll see mostly on their hands to start and their face. Subcutaneous tissue may atrophy, um, reducing insulation and padding over bony prominences, which will potentiate pressure ulcers and nail growth slows and hair growth patterns change. Risk factors that affect skin wellness, chronic illnesses, immobility, poor nutrition, dehydration, all the same stuff that really affects everything else. Here incontinence is going to come into play, and decreased sensation will also increase skin vulnerability. Medications like sulfonamides, tetracyclines, and amiodarone may cause photosensitivity, increasing the risk for sunburn, environmental exposure, particularly ultraviolet radiation, so the UV rays, is a major contributor to skin aging and skin care. So the use of SPF earlier in life, as we all know, is linked to healthier skin outcomes. Functional consequences of consequences of skin changes, dry skin, itching, delayed wound healing, increased susceptibility to skin tears, and increased risk for pressure ulcers. The moisture associated skin damage that can come along with incontinence, like prolonged exposure to stool, urine, or precipitation, um, is also going to be like one of those more specific to the geriatric population, especially those who are bedbound. Skin cancer is linked to long-term UV exposure. The most common types are basal cell carcinoma, squamous cell carcinoma, and melanoma. The early recognition is really the key to not surviving, but removing and mitigating this type of cancer. It is very much survivable, and most people go into remission as long as it's caught before it metastasizes. The ABCDE guide assists in identifying suspicious lesions, and that's the asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving appearance. Something that follows all of those guidelines is going to be much more of a red flag. Um, let's see. We kind of covered these risk factors here. What type of medication is most often associated with photosensitivity? We did talk about the sulfonamides. Um, let's see, but there's a handful of other ones that do as well. And that's listed here in her rationale. So pay attention to those. Pressure injuries is a big issue with our bedbound population that results from prolonged pressure or pressure combined with shear. They commonly, Lainey, please stop, stop, stop. Um, sorry, let's see. Commonly develop over bony prominences in individuals with limited mobility. Pressure ulcers are considered preventable and are associated with increased mortality and healthcare costs. Um, And like we all know, that's not limited just to like the coccyx bone, the heels. It can also happen from medical devices such as oxygen tubing and intubation equipment. Um, so it's important to assess the skin as a whole and not just like the higher risk portions. So that skin assessment is going to include color, moisture, temperature, turgor, lesions, wounds, and the skin integrity itself. In older adults, skin turgor should be assessed over the sternum for more accurate hydration evaluation because, like we said, the elasticity in the peripheral parts of the body, like the face and the hands, is going to be a lot less. It's going to be in much more compromised. But the skin over the sternum is going to be always a little bit more taut. Here's a list of the ways that you should be documenting wounds, size, depth, edges, color, drainage, and odor, tunneling, and surrounding tissue appearance. Those are all skills that you'll learn as kind of time goes on. Um, but just keep in mind that those are what can be causing those issues. We're talking about that. We covered that. Um, the use of the Braden scale is going to be the best practice for risk identification for pressure ulcers. And then once a pressure ulcer is identified, the staging system is important to know. Um, and I'm sure she covers it. The stage one is just the epidermis. Stage two is going to include the dermis. Stage three goes into those underlying tissues, and stage four goes all the way to the bone. Um, there's also the two other ones. I think it's unstageable and a deep pressure wound. And the unstageables obviously are at a point where you can't know where they like what they are because they're so far advanced. Or if they've started to heal over. And then the deep pressure wounds are like big bruises, but they're not, they're like a very deep, deep color. They're not like that bluish or purplish color that a normal bruise would be, and they're often over bony prominences. Um, nursing assessment we talked about looks like she references a couple of boxes and tables here. Um, checkpoint is where to check for that skin turgor. We're going to do the sternum. Um, and then our nursing interventions are going to be to maintain hygiene, prevent dryness, use moisturizers, and avoid friction and shear. Um, that's going to be like the avoiding the friction and the shear bless you, comes from typically the sheets on the bed, like pulling the sheets underneath them too hard will result in a shear. Repositioning patients every 2 hours, but doing it the right way. Like I said, avoiding pulling or shearing the blankets. Use the appropriate support surfaces to reduce pressure. They do make like particular types of foam. They use like Mepilex dressings over um, wounds that already exist. Um, placing pressure reducing devices underneath oxygen tubing and the intubation equipment is important. Hearing aids can also cause the same thing. They do make pads for those as well. Making sure to keep the skin clean and dry, manage incontinence properly and promptly, and then promote adequate protein and hydration to support healing. Um, Monitor for wounds, signs of wound deterioration, such as increased size, slough, exudate, or delayed healing. Um, there are examples of how to know it's not healing well. These are pictures of what exudate, slough, or eschar looks like. Tunneling is a sign that that it's not healing well. Chronic wounds are wounds that last longer than 6 weeks. You'll see these a lot on the lower extremities with people who have diabetes, PVD, or end-stage renal. These are those positioning, the prevention pads, pillows, and um, things like that. This is an example of how to position a patient to avoid the bony prominences. And looks like she's got a nursing diagnosis question here for a patient with a stage 3 injury. Um, so whatever topic she's really pulling through here in her um, example questions, I would pay close attention to. Uh, please. Um, know some general information about the Braden scale. I think it's in your book. And things that we're looking for, the alleviation of complaints, evaluate responses to the interventions and the effectiveness of interventions for pressure ulcers by the rate of healing and prevention of complications. So that's going to cover that. If you guys have any questions, let me know. Sorry for the interruptions, but that's what having a toddler is like. And if you guys need anything, just feel free to reach out. I will stop sharing my screen and end the recording. Thanks for listening, and I will hear from you guys if you need me.
Thank you.